It's my great pleasure to introduce Dr. Donna Mancini, an international leader in heart failure and cardiac transplantation, someone who's touched the lives of so many patients and so many fellows and colleagues that she's trained. Dr. Donna Mancini is the head of heart failure and transplantation at the Mount Sinai Hospital. She is a professor in the Department of Cardiology and in the Department of Population Health Science and Policy. She completed her training at Albert Einstein College of Medicine. She went on to be the director of the heart transplant program at Columbia for many, many years. In addition to her busy clinical practice, Dr. Mancini has been a leader in heart failure research where she's focused on exercise physiology and risk stratification for selection of advanced heart failure therapies. She's also researched post-transplant management, including immunotherapies. She has served on the editorial boards of several journals. Her clinical research has been cited thousands of times. She's given countless of lectures around the United States and internationally. She's co-authored the ACC-AHA guideline documents for the management of heart failure. And of course, her work on cardiopulmonary exercise testing is included in the guidelines for transplant candidate selection. So without further ado, please join me in welcoming Dr. Mancini. Thanks, Dr. Mancini.
Steve, I'm going to mute your place there because it's often noisy.
Oh, yeah, thank you.
Hi, can you hear me? Can you hear me?
Yes, Donna, we're fine.
Okay, great. So Dr. Goldman asked me to talk about cardiac transplantation new developments. And quite frankly, I'm really not able to cover all the new developments. So I have highlighted a couple of major changes that have been happening over the past couple of years in heart transplantation. But before I get into that, I do want to just review for the fellows who I didn't have an opportunity to speak to this summer, just the basics of the heart transplant evaluation and the reasons why we go into what we do when they see these patients in the hospital. Last week, we had a wonderful grand rounds by Dr. Januzzi, where he reviewed the current treatment for heart failure. And this slide illustrates all the therapeutic options we now have for patients with stage C and D heart failure. And it's pretty amazing, all the possible therapies that are now available, from hormonal blockade to devices. Okay, how come I can't advance? Okay, right. So we're coming up to the anniversary of the first heart transplant. And this is Christian Bernard with Louis Wastowski, who was a greengrocer in Cape Town, South Africa. He was transplanted on December 3rd, 1967. And just for reference, at the time of his transplant, he had anasarca, and the only medications he had were DIG and mercurial diuretics. So it's amazing in how over just 50 years, we've advanced so much in the treatment of heart failure. But no matter all the advances that we've had, patients with stage C and D heart failure ultimately spiral down and end up with stage D heart failure, where the therapeutic options are really just limited to heart therapy or mechanical support or palliation. When a patient's referred for refractory heart failure in clinic, what we do is make sure that reversible factors are corrected, that if there's evidence for ischemia that's treated, if the patient is taking non-steroidals, that's stopped, if they're alcoholic, that they're abstinent, we optimize medical therapy. If they're in the hospital and they end up being inotrope dependent, that is when we try to withdraw the parental inotropes, they develop worsening heart failure, hypertension, end organ damage. then it's easy. Then we know we're at checkmate and they're stage D and they're refractory, and the only options are transplant, LVAD, or hospice. But if they're not dependent on inotropes, then we have to collect several prognostic variables. And the current selection criteria for transplant candidates listed on the slide, they're basically patients with end-stage heart failure, class 3B and 4, despite optimal medical therapy, remarkably reduced ejection fractions, peak VO2s that are less than 12, or they have refractory malignant ventricular arrhythmias, or they have inoperable coronary disease with Canadian class 4 angina. And as I said, inotrope dependence is a key marker because you can see this survival curve of patients who are on inotropes and not on inotropes. And you can see that at 1 year, if a patient is truly inotrope dependent, their survival is in the order of 25%. So, that's a good point in terms of determining eligibility for transplant or for LVAD. But if they are ambulatory, one factor that I have spent a good part of my career focused on is exercise capacity and the measurement of peak oxygen consumption. And peak oxygen consumption is a good way to assess cardiac reserve. It's derived from the thick ratio, VO2 equals cardiac output times the AVO2 difference. And as most individuals would come to the same AVO2 difference, the exception being if you're a trained athlete and you can really widen out your AVO2 difference. But most patients will come to the same AVO2 difference. So what VO2 provides is an indirect assessment of your ability to increase your cardiac output. It also provides a way to assess your pulmonary vasculature. And we see that in some of the ancillary data that we collect at the time of cardiopulmonary exercise testing with the VE-VCO2 ratio. And it also assesses our ability to extract oxygen and thus assesses the peripheral vasculature and the muscle. And it really is an overall measure of fitness in cardiac reserve. And many years ago, I did a study using VO2 to guide transplant candidate selection. And what I saw was that if your VO2 was greater than 4 mets, you had a 1-year survival that was around 85%. If the VO2 was less than 4 mets or less than 14, the 1-year survival was markedly decreased. And these are patients who were not transplanted, and these were patients who ultimately were transplanted, so they were censored at the time of transplant. So this was a test that was able to really distinguish patients that you could safely defer transplant. And ultimately, this got accepted into the guidelines and is used worldwide. And, basically, if you had a peak VO2 less than 14 in patients who are intolerant of beta blockers, that's considered a prime criteria for listing for transplant. And if you're on beta blockers, a peak VO2 less than 12. And then for young patients and women, we consider a percent predicted peak VO2 because VO2 depends a lot on gender and age. Also, it's never good to just rely on one variable when deciding on the prognosis of a patient. At the time of the transplant evaluation, we collect many different prognostic variables, and to have a more robust selection process, I went on with my colleague Keith Aronson to develop a heart failure survival score to better estimate survival in patients with ambulatory heart failure. And it consisted of 7 variables: the presence or absence of coronary artery disease, the heart rate, the mean arterial pressure, the left ventricular ejection fraction, peak VO2, serum sodium, and IVCD. You know that when you create models, you can, the input of the statistician and the physicians that are creating the models are important. And The reasons why we focused on these 7 variables were they were all non-invasive variables, and they were all variables that were independent of physician or patient bias. This heart failure survival score is still used in many centers, both in the US and internationally. And it's one of the strongest predictive tools that is available. The Seattle Heart Failure Model subsequently was developed and is available on the internet, and you can calculate 1 5-year survival. And if your 1-year survival by the Seattle Heart Failure Model is less than 80%, you're considered to be a good candidate for a transplant listing. And then there are other models that have been developed. The Seattle Heart Failure Model has around 15 different parameters and includes the impact of different medical therapies on outcome in patients with heart failure. And as I said, it's very popular because you can go to the internet, plug in your patient's data, and come up with expected 1 to 5-year survival. Another component of the heart transplant evaluation that's really critical is the right heart catheterization. And the reason for this is that patients who go on to transplant, if they have severe pulmonary hypertension, which is not reversible, they are at increased risk to develop right heart failure at the time of transplant. And so the right heart cath is an important part of the transplant evaluation and something that the fellows will be helping us with in the cath lab. And it's important that patients who have elevated pulmonary pressures, that's a PA systolic pressure greater than 50, a mean PA greater than 30, a transpulmonary gradient that greater than 15, PVR that's greater than 3 Woods units, that they do get a vasodilator challenge. And unfortunately, too often we have to remind our interventional colleagues not to forget to do this. If the PVR remains elevated, despite the vasodilator challenge, then we have to intervene on the patient with either a trial of chronic parenteral IV inotropes, treatment with phosphodiesterase inhibitors, or placement of an LVAD. And the classification of pulmonary hypertension severity is shown on this slide. Basically, if it's severe or moderate, it is it's problematic for proceeding directly to heart transplant. So what are the components of the transplant evaluation? One is to assess the severity of the cardiac disease. We need to exclude all medical and surgical options. The critical components for the cardiac evaluation are the right heart catheterization. If a patient has not had a left heart catheterization and has symptoms that are suggestive of ischemia, that also needs to be done. Exercise testing or measurement of oxygen consumption, endomyocardial biopsy if there is concern that there's restricted cardiomyopathy, and assessment of myocardial viability. The second component of the heart transplant evaluation is the exclusion of significant comorbidities. And we spend a good part of our time going through a long list of potential comorbidities that can impact post-transplant survival. And they're shown on the slide. Age is a variable exclusion criteria. And in some centers, the upper age limit will be 70 years. In other centers, it will be 75 years. But basically, a heart transplant can, on average, patients survive around 12 to 14 years. That's 50% survival. And some patients can survive up to 30 years. So the use of cardiac transplant in patients who are in the 70s is really quite debatable because it may not be the best use of a scarce resource because the transplant can outlive the lifespan of the recipient. As we said, fixed PVR is a contraindication. Recent peptic ulcer disease because of risk of bleeding in the perioperative period, especially since patients are on high doses of steroids, and also because the ulcer crater can be colonized with CMV in Canada. Pulmonary infarction is a relative contraindication for a couple of months so that the infarct heals. And if we go ahead and we do transplant again with treatment of high dose steroids, a unhealed pulmonary infarct can develop into a pulmonary abscess if the patient develops pneumonia. If you have significant end organ damage to diabetes or brittle diabetes, nowadays it's not infrequent for us to do heart kidney transplants. Comorbid illnesses with a life expectancy less than 2 years, symptomatic severe peripheral vascular disease, difficult to control hypertension, severe obesity, drug, tobacco, alcohol abuse within the past 6 months, psychosocial instability, active release of malignancy. As you can see, it's a long list. And when the patients undergo the transplant evaluation, they do undergo a large series of tests to exclude these comorbidities. At the last part of the transplant evaluation is the psychosocial evaluation. And we really need to make sure that the patients have the ability to care for themselves, that they have the financial means to care for themselves, that they can comply with a complex medical regimen, and that they are free of self-abusive behaviors. Most of the patients who are listed for transplant, 90% have heart failure with reduced ejection fraction. And then the other candidates are patients who have hypertrophic cardiomyopathy, restrictive infiltrative cardiomyopathies, congenital heart disease, need for retransplant, refractory CAD, and refractory ventricular arrhythmias. And one of the boons of the drug epidemic in the United States has been a recent increase in the number of transplants that are done in the US. And now we're at approximately 3,000 transplants annually. And this is data from our SHLT registry, which is a good registry to look at the trends that are happening in transplant in North America versus Europe. This is the transplant volume and survival at Sinai. You can see that we're a mid-range volume center, and that over the last couple of years, our survival has improved. And again, this is data from the ISHLT. You can see that Sinai fits into this 20 to 29 transplant volume done annually. And as such, it's in the top quarter of transplant centers in regard to volume. A couple of recent changes in heart transplant that I wanted to talk about: the changes in the allocation system, changes in the information that is provided to patients, changes in organ preservation, and changes in allograft rejection monitoring. And in 1986, the United Network of Sharing was founded by the government. And the US was divided into 11 different regions, where Region 9, and Region 9 consists of New York and actually Vermont. Region 2 is New Jersey, Pennsylvania, Delaware, Maryland. Region 1 is the Northeast, and Region 5 is California. And these territories have not been changed over the last 40 years. And UNOS is in charge of allocating organs and deciding which recipients should receive the organs. And there's an allocation system that we will use, and probably every 10 to 15 years, there is a revision of the allocation system. Prior to the most recent revision, there was a revision in 2006. And in 2006, it was changed so that the allocation of organs by priority statuses was really dominated by the activity of the OPOs within the region. And because of this change in the way that the organs were allocated, it led to significant regional differences. And according to the final rule, and the final rule which UNOS is mandated to follow, that organs ought to be allocated to the sickest patients first over as broad a geographic region as is feasible. This allocation system was in violation of the final rule. For example, from 2006 to 2018, the waitlist time for someone in New Jersey was roughly 1/3 the waitlist time for someone who was in New York. And so, if you simply went over the bridge and got listed in the different UNOS territory, you can significantly decrease your waitlist time. And that was really unacceptable. And, basically, I wrote a couple of papers. One was about the differences in waitlist time by regions before and after the change in the allocation system. You can see that in Region 9, there was a 67% increase in the waitlist time. If you were status 1A, and if you were status 1B, there was a 70% increase in waitlist time. The other thing that the change in the allocation system resulted in was that there was a significant difference in the use of elevators at transplant. Because of the longer waitlist time, certain regions like Region 9, the patients who underwent transplant in the initial era was only 3.5%, and then subsequent to the new allocation system with the increased wait times, it was 29%. And you can see that there was a variation in the use of LVADs related to variation in waitlist time because of abnormalities in the system.
How are you?
The other thing that was happening is that candidates are allowed to be listed at multiple centers, and not all centers have uniform candidate criteria to list candidates, and insurance just does not cover travel related costs to other centers. So the ability to get multiply listed was really something that the more fluent patients had. That was another unfair advantage. And again, writing with one of my colleagues at Columbia, we demonstrated that there was this practice that was ongoing, and these multi-listed patients had shorter waits, and they were more often white and male and privately insured and had higher income and higher education. So the problem with geographic differences, the problems with multi-listing ultimately led to a change in the heart allocation system. No, what I advocated for was really just broader sharing for patients who are status 1A and status 1B, that is opening up the region so that you weren't so dependent on your particular donor-specific area, but you had 500-mile zones so that the organs could go between regions. And that would have been a simple thing. But UNOS decided that they were going to do a major overhaul. They were going to do new status classifications and new qualifying criteria. They were going to create 6 tiers so that they can better stratify patients for status 1. They wanted to have broader sharing for critically ill patients. Weren't in all of the status 1 tiers, 1A tiers, but status 1 and 2. And then the other problem that was happening is that every time you apply for a status, there is a way that you can get around meeting the qualifying criteria. And that is you can write a narrative and state your case as to why you think that this patient merits higher priority status. And in the old system, there were lots of narratives that were written to upgrade patients' priorities. So UNOS and the Graft committee decided they were going to do a major overhaul. They wanted to better stratify patients according to waitlist mortality. They wanted to improve access of donors to critically ill patients, and they wanted to reduce the burden of exception requests. And on October 18th, 2018, there was this big shift from the status 1A, 1B, and 2 categories to a 6-tiered system. And so status 1A went to status 1, 2, and 3, status 1B went to 4 and 5, status 2 became status 6. And this shows in more detail what the different statuses are. So status 1 is a patient who is supported by VA ECMO or has a mechanical device with intractable VT or has a non-dischargeable BiVAD. Status 2 is a non-dischargeable LVAD, the presence of an anterior balloon pump, a total artificial heart, a BiVAD, a mechanical assist device with device malfunction, VT or VF in a non-bad patient. Status 3 is 30-day for LVAD, multiple inotropes and 1 inotropes with a SWAN in an ICU, a VAD with certain complications. And if you were on VA ECMO or on a balloon pump, you had 14 days to transition to a durable LVAD, or you become a status 3. And then status 4 were LVADs, chronic LVADs that were home, or patients who were stable on parenteral inotropes. And also now patients who had congenital heart disease, who were retransplanted, had infiltrated diseases, they were also given a higher status. And then status 5 and 6 and 7 wasn't active. And you can see that the criteria that you have to put in to justify these categories is shown in this slide. For example, it's really kind of vigorous, especially if you have like VT or VF. You have to show that the patient's not a candidate with failed ablation. You have to have greater than 3 episodes of VT or VFib separated by an hour with normal electrolytes. And you need to show that you need cardioversion despite IV antiarrhythmics. And with the VA ECMO, there are hemodynamic criteria that you have to meet. And again, this just shows, all the criteria you have to put in. But remember, after all these statuses, you can always write a negative. And if someone doesn't totally meet it, you can plead your case as to why you think that patient should have a higher status. So the next few slides show what's been happening before and after the change in the allocation system. This is waitlist additions by status and era. The pre is the 1 year before the change in the allocation system. The post is the 1 year after the change in the allocation system. And one thing you can see is that there is an increase in what would be the old status 1As, because that's status 1, status 2, and status 3 equals status 1A. So there's a shift to a higher percentage of high priority patients, a little reduction in the 1Bs, and less listing of status 2 patients. Also, if you look at the devices in the year before and the year after the changes in the allocation system, you see that there's an increased use of ECMO. There's a significant increase in use in the intra-aortic balloon pump. There's a decrease in chronic LVADs. But one thing that the new allocation system seemed to get right is that this is deaths per 100 patient years. These are the previous statuses. These are the current statuses. You can see that for status 1, 2, and 3, the new allocation system can risk stratify patients who are on the wait list. So the new allocation system does identify patients who are in the most urgent need for transplant. So how did the new allocation system impact outcomes post-transplant? Again, in the year before the change, there were 4,300 heart transplants, and the year after, there were 4,400 transplants. And you can see that in terms of these severity of transplant at listing, there's a shift to more 1A patients because status 1, 2, and 3 are equivalent to 1A, and there's a decrease in 1B patients. Okay, let's see. Okay, all right. And the thing that was really pretty incredible is that with border sharing, patients with adult status 1 and adult status 2, the average median wait time to transplant was only 5 days in status 1 and 10 days in status 2. And for status 3, it's 28 days. So patients who were previous 1A really got prioritized and are going much faster to heart transplant. So let's look at the devices now that are present at the time of the era. And the thing that you'll notice is that with the new allocation system, there's definitely more ECMO use. ECMO use has increased by the order of 5%. The other thing that's really pretty amazing is that now almost 40% of the patients at the time of transplant are supported with balloon pumps. There's a reduction in the number of LVADs, and it's about the same in terms of ventricular support. So LVADs still account for the large portion of devices, followed closely by intra-aortic balloon pumps. And there's a substantial increase in intra-aortic balloon pump and decrease in LVAD. And, you know, it's really a problem, which I'll talk about a little bit in the next couple of slides. So in terms of before the policy change and after the policy change, there's a decrease in risk of death or deterioration with the new policy system, but there seems to be a trend towards decreased survival post-transplant, and that's in part due to the increased use of ECMO. If you look at the data from the SRTR, again, there's a tendency to have slightly less survival in the new post-allocation scheme era, but it doesn't meet statistical significance. But if you look at the SRTR data and you divide them into the different strata, and this is strata 1 with ECMO, you can see that there is slightly reduced survival. It doesn't meet statistical significance, and in actuality, 6 months survival is still 88% in patients who almost universally would be dead. So, whether there's, an overall benefit to the use of the organ, or whether it's a bad use of the organ is not yet known. But, basically what's happened in the transplant community is that there's developed these two tracks. And there's a fast versus a slow track to transplant. What's happening now that patients are coming in cardiogenic shock. They're either in acute shock or they're chronic heart patients who develop intractable cardiogenic shock. And they're being triaged to either the fast track, where they get ECMO, balloon pump, some kind of percutaneous support, and go on to transplant within 14 days, or they get the standard treatment, which is inotropes, durable LVAD, and then wait months to years to transplant. And it's really not clear which track is the right track. And quite frankly, when the revision of the allocation system went into effect, it was not to create these two tracks. It was really trying to triage the use of transplant for patients who could not be supported just with an LVAD. It was trying to identify patients who were at the highest risk of mortality, who could not tolerate just LVAD therapy, and who would really benefit from going to quicker transplant. But the reality is that the transplant physicians are not keeping in the spirit of the new allocation system, but they're actually biasing the system, diluting out the potential advantage for patients who can't get LVADs, and creating these fast and slow tracks. And so, for example, you have a 67-year-old man with end-stage ischemic heart disease who's been listed as a status 6 for quite some time. He's admitted with acute decompensated heart failure. He's been complying with an excellent medical regimen consisting of maximum hormonal blockade. There's no clear precipitant of worsening heart failure. On admission, he has a blood pressure of 85 systolic. He has a pulse of 105. He has evidence of biventricular failure. He started on milrinone. He initially responds, but then he develops progressive renal insufficiency. He has pro-BNP that is in the thousands. His milrinone is increased. He's transferred to CCU. He has a right heart cath with dismal hemodynamics. And what's the next step? Do you put in a chronic LVAD, or do you put in a balloon pump? And depending on what center you are in, it's going to be a difference in treatment. And, it's quite frankly, that patient should get an LVAD, and the patient should get a trial of treatment with chronic durable mechanical support. But now with different centers, the fast track is intra-aortic balloon pump to transplant. The other thing that's happening is that in 2019, there was a change in how transplant center performance is reported out by the SRTR. Before, what used to be reported out was the hazard ratios observed over expected results. They would dry, you would see these bell curves. As a lay person, it was really hard to really understand the differences between centers. So the SRTR felt that they wanted to make a more user-friendly application for patients. So the patients could just look at different programs in the region and figure out which program they should go to. And so what the SRTR did was they did a bunch of statistical manipulations so that they create the hazard function, the bell curve, and they get the observed over expected ratio, and then they look at the contour of the bell curve, whether it's a nice triangular or whether it's a wide curve. And from that, they do a lot of statistical manipulations, and they ultimately convert it into a score from 0 to 1. And if you're closer to 1, you get 5 bars. If you're closer to 0, you get 1 bar. And so we get these like ratings on the internet. And if you go to the SRTR and you Google, you put in your zip code, the transplant programs within 50-mile radius will come up, and you'll get the rankings in terms of survival on the wait list, which center will get you a faster transplant, what their 1-year survival is. So this is what you see. You know, this is a center in Manhattan, and you can see that this one really performs great in terms of getting you a transplant faster. Plus, you have a terrific 1-year survival. This is very bad in terms of getting a transplant faster. And even though you wait longer, your survival is not that great. And this one, you gotta wait long, at least your survival is almost there. So, you know, if you're a patient, you're seeing this, where are you gonna go? You're gonna go to the one that has 5 stars and 4 stars. I don't really think that this is a good comparison because it really doesn't factor in all the nuances, and it also creates a highly competitive field. And it's like comparing 3 programs that know what they're doing on a very crude basis. So I've been trying to advocate for them to get rid of these new store systems. The next thing that's really been changing is donor procurement. And these are the criteria that we look for in accepting a donor. We'd like to have a donor that's less than 50 with negative serologies, normal echo, no TG, no active systemic infection, no malignancies, no significant comorbidities, low inotrope requirement, no history of downtime, size matched well, immunologically matched well. But due to the donor shortage, we frequently are forced to take donors that are not optimal. They're older, they may have high dose inotropes, they may have some OVH on echo, they may be a long distance procurement with a long ischemic time, there may be some cardiac risk factors, but these high-risk donors do have immunologic consequences and the consequence of increased incidence of primary graft failure. Primary graft failure is a problem that has recently developed over the last 10 years in heart transplant. Before that, the incidence of primary graft failure was not that high. And when I say primary graft failure, I mean that the transplanted heart has an adequate function in 24 hours. And it's not the result of hyperacute rejection. It's not the result of some intraoperative calamity. It's not the result of severe right heart failure from the patient that goes in with high pulmonary vascular resistance. And there are donor factors, recipient factors, and procedural factors that contribute to the development of primary graft failure. Age, the need for high inotropic support for the donor, Patients who, donors that have cerebrovascular disease and die from cerebral hemorrhage have a higher chance of developing primary graft failure. Recipient factors include patients who have been on long-term mechanical support, who have comorbidities, and then procedural factors, long ischemic time, recipient donor mismatching, female donor to a male recipient, etc. And the development of primary graft failure in literature is very variable. It can range anywhere from 2 to 26%. And the consequence of primary graft failure is really an increase in mortality. And again, that 30-day mortality can range anywhere from 14 to 80%. And in terms of trying to define what primary graft dysfunction is, in 2014, there was a consensus conference where the heads of the different transplant programs met, and we developed a classification of primary graft failure, which would help to make reporting more uniform across centers. And the two levels, the grade 2 and the grade 3, moderate and severe primary graft dysfunction. Moderate is high doses of inotropes that last for several days, with the evidence of LV dysfunction or RV dysfunction on echo. And grade 3 is simple to see if you need mechanical support coming out of the OR. And it's really these grade 2 and the grade 3 primary graft dysfunction, which is associated with decreased survival and increased morbidity. And this is a study that was published in 2019 from Heather Ross and colleagues at the University of Toronto using the ISHLT classification system and showing that the patients who had severe PGD had significantly reduced survival at 1 year, and also moderate PGD was also associated with decreased survival. There are a couple of reports that also describe the increase in ICU stay, the increased duration of hospitalization, the increased incidence of postoperative infections in patients who develop PGD. So it's an important thing. But unfortunately, neither UNOS nor the ISHLT collect the data fields to accurately define the problem. And so working with the thoracic committee, we are revising the data transmission forms so that we can better quantify this adverse outcome and better understand how often this is happening. And this is particularly important because there are a lot of changes that are happening in donor procurement. Basically right now, the vast majority of hearts are procured using cold ischemia. So basically, at the time of the procurement, the heart is excised and put into a container that is filled with ice, and the patient organ is brought to the recipient center. And this cold preservation is associated with ischemic injury. There's no way to assess the organ prior to transplanting the patient because of the risk for ischemic injury. There's a limitation to the time or distance you can go to get the organs. And generally, beyond 4 hours of cold ischemia, there's an increased incidence of primary graft dysfunction. So there have been ways, we've been looking for ways to better preserve the heart so that we can not have these issues. And there is a device that has been developed for warm preservation, which is called the organ care system. There's another device that's also been developed, but this is the one that's really only available in the United States. Is the Transmedics. It's basically takes the procured heart, puts it in a Langendorf's preparation. The heart is perfused with blood from the donor and with a solution, and you can sample from this line and see the lactate that's being formed, the pH, and essentially it's like a Langendorf's preparation. So it's a physiologic preservation. It's got resuscitative capacities. You can assess its metabolic effects on the organ. With this, you can expand the time and the distance the heart can be out of the body, and potentially you can improve utilization. And the OCS trials so far that have been done include the PROCEED trial, which was published in The Lancet in 2015, where they looked at 62 standard heart donors and compared them to 62 patients with cold ischemia, and the outcomes were comparable. And these were normal donors. So using either cold or warm preservation, you had similar outcomes with the initial trial. The second trial, which has not yet been published, is the OCS Expand trial. And this is a trial where there was extended donors that were used. That is, donors that had some mild coronary artery disease, donors that had left ventricular hypertrophy, donors where the anticipated ischemic time would be more than 4 hours. And so far there are 122 patients that they have investigated. And the initial data, which is being submitted to the FDA, really shows that these hearts do well, that there's only 11% incidence of primary graft dysfunction, which is actually on par with was reported by most centers, and actually lower than in several centers. And now in 2019 to 2020, this device is being used to resuscitate donors after cardiac death. And that's in an ongoing trial. And as of October of this year, so far 90 patients in the United States were transplanted using DCD donors. And what is DCD donors? What's a DCD donors? What is the donation after cardiac death? You know that when patients die, they can come into the ER dead, and that's totally uncontrolled. You don't know how long they're down, it's not a great situation. And then you can have people that are unsuccessfully resuscitated in the ER. Again, that's, relatively uncontrolled, but can be converted into a controlled situation. And then there are patients who you're going to withdraw therapy, and those people are awaiting cardiac arrest, and that's a controlled environment. And then there are patients who are brain dead, who have a cardiac arrest, and that also is relatively controlled. And then you have unsuccessful resuscitation in the hospital. So right now, the major focus is on patients who are going to have withdrawal of care. But there are a lot of ethical issues with this. And, basically, one of the rules that are followed in transplant is that organs are procured only after the donor is dead. And how do you define death? You can define brain dead, which is fine. But if you define death at the stoppage of heart activity, and then you restart the heart. You're sort of in like a conundrum. So in a lot of regions of the world, in Europe, DCT donation is not allowed. And even in the United States, the state laws are not uniform in terms of DCD donation. So, but DCD donation is happening. The investigators in Australia and in England at Pembroke Hospital have been using DCD donation in heart transplant patients. And again, as I said, it's mostly the patients with category 3 Maastricht class, so that they are patients who you're going to for life support. And, you know, basically, this is what's used mostly in Australia and is used in the OCS DCD protocol in the United States. So basically what happens is, you know, a patient is close to brain death, but they are not brain dead yet. They're in the ICU. In the ICU, you have a declaration. You have a declaration of circulatory death. You draw taking off the respirator. You wait for them to have the sensation of circulation. You have a 5-minute standoff, and it depends. Some places it's 2 minutes, some places it's 30 minutes. In Italy, it's going to be 20 minutes. And then the donor team comes in, they move to the operating room, they do the sternotomy, they arrest the heart, and they reanimate it with the transmedics device. That's what's happening in the DCD protocol that's going on in the United States. And actually, we're going back to Louis Witkowski, because Louis Witkowski, when he had his first heart transplant on December 3rd, 1967, the donor was in the adjacent operating room. And basically what happened was the donor team, the surgeon excised the heart from the donor and walked the heart over to Louis Witkowski. Then there's normothermic regional perfusion, DCD heart protocol. And in this one, you have a patient in the ICU, he's not really brain dead, but he's close to being brain dead. You would draw life-sustaining interventions. You declare circulatory death. You wait a period, you know, whether it's 5 minutes, whether it's 10 minutes, whether it's 2 minutes, it's all very variable. The donor team comes in, they do a sternotomy, they clamp the head vessels, they clamp the carotids, the subclavian innominate arteries. They initiate coronary bypass. They reanimate the heart in the body. They reintubate. They wean them from bypass. They assess the heart in the body, and then they excise the heart and put it in cold storage and bring it to the donor hospital, to the recipient hospital. And this one is really sort of problematic because you have this reanimation phase that's happening in the donor. And so you're sort of reversing the fact that there was a sensation of circulation. This is what our colleagues at NYU are actually doing. And some other transplant centers, like University of Michigan, has investigational protocol using this normothermic regional perfusion. So I think it's pretty late, so I'm going to stop here. The other thing I have wanted to talk about is there are now more and more non-invasive ways to detect allograft rejection. And I'm just going to show you my favorite one, which is the molecular microscope. I really like the molecular microscope. The molecular microscope combines both tissue diagnosis with mRNA changes in the tissue and can help you sort out whether you have humoral rejection, cellular rejection, ischemic injury. And so you have a combination of both the molecular changes in the tissue as well as the histologic changes in the tissue. I really like this one the best, more than the other blood changes. But I'm going to stop here and ask if anyone has any questions. I put everybody to sleep. I know I did.
I also muted everybody, so please unmute yourselves to ask questions. Dr. Mancini. Donna, thank you.
Donna, Marty Goldman, that was really a fantastic overview, and of course, your experience is just tremendous as a leader in the field. So one of the processes is that we are doing mechanical support too late and then going to transplant too late. Is there a trend now to consider, mechanical support earlier in the course of patients with end-stage heart failure to give them a better prognosis if and when they get the heart?
No, the way the allocation system is working now is that patients who are on durable will get support or disadvantaged. The patients who are on temporary support are the ones that are going to transplant. So unfortunately, I don't think we can really do that type of study. And I think, unfortunately, the allocation system is going to need to be redone. And I think the fault of the allocation system is that rather than emphasizing the severity of cardiac dysfunction of the patient, there is too much a component of the treatment that's being applied. And I think somehow we have to remove that treatment element because no matter what we do, good doctors feel they're doing what they should to advocate for their patient and to move their patient along. And they have good intentions, but we need a more objective system that is devoid of any emotional input. I need some help with some ideas so I can figure out and propose to the community how to do that. Because I think unless we figure it out, what's happening more and more is government regulation and government crunching of data, which really isn't the greatest data, to have us do, certain things in the treatment of our patients.
Dr. Mancini, this is Anu. Thank you so much for an incredible overview and talk. It's amazing how much we learn each time we listen. Question for you as to policy shifting or changing. We have broader sharing for those patients who are the most acutely ill, so the status 1s and the status 2s. But what we're noticing as a result is that local donors are less available for those patients who are status 3, status 4, et cetera. Do you foresee broader sharing becoming available to the patients who are still quite sick, quite frankly, but don't meet criteria as per how UNOS has laid them out? And do you think that that would have a positive effect?
I think that there should be broader sharing for all patients. Unfortunately, that's a politically charged issue. And it has to do with the local procurement agencies in the states. And the best we've been able to do so far is just get quota sharing for status 1 and status 2. This really should be independent of politics, but it really isn't.
Hi, Donna. And do you think now that we are confronted with this reality that you have to choose either you go mechanical root support for a couple of years versus transplant with patients?
Yeah, I think it's a problem. And actually, the Killick article that I showed with survival curves that suggest there's been a increase in mortality post-transplant with the new allocation system. It was really a scathing editorial by the editors of JAMA that recommended that the new allocation system be abandoned. So I think that there will be changes, but you know, the problem is that policy change moves very slowly in those. And you know, another thing that they're working on is a continuous model of distribution, which would be one where geography and the illness of the patient would both be factored into the allocation of organs. And that's also supposed to be becoming available for some of the organs and then ultimately rolling out to the heart. So there's going to be a lot of change.
If no further questions, thank you so much, Dr. Mancini.
Thank you.